Hey, how's it going, Charlotte family? Hope you guys are doing good. I can't believe it's already June. We're already halfway through the year, and thanks for hopping on today. If you've been hopping on recently, we've been going through some Hospice 101 live education. The word hospice is scary, and over the years, we've been serving the Metroplex for about more than 20 years now. We're established in 2003, and we've seen a lot of just confusion when it comes to hospice care. And also, the word hospice is just scary because a lot of people think that hospice means death right away. And Medicare created hospice to support families and support patients if they qualify clinically. So we've been doing this since the beginning of the year, these lives, and just to educate families to help them understand what hospice is. And so this last month was Stroke Awareness Month. And so we do have one more patient that we wanted to talk about today. And then we'll do a different series this month regarding a clinical guidance for hospice qualifications. And today we're going to talk about a gentleman who was a previous patient of ours that what we've done is retold the stories for HIPAA purposes, and also help you understand specifically how this story could relate to you, your loved one, or someone that you may know that may need hospice services. And so we're going to take you through his journey on home health and how he did well on home health and was going through his battle with stroke, and then how the decline continued to happen, and then he went on to hospice services. So thank you for hopping on, and looking forward to enjoying this time with you. Thank you for your lunch break. If you're on a lunch break, I'm sure you're just watching real quick, and we appreciate you. So let's get right into it. So hospice, the word hospice is super scary, but there's some statistics that a lot of people need to know. And I don't know if you remember, a couple years ago, President Jimmy Carter was on hospice, and he was on hospice for more than a year, but he qualified clinically. And a lot of times what we talk to families about is, if you do qualify, there is support clinically for the patient and for family members. But on average, is only about 18 to 21 days that people are utilizing the benefit of hospice, when it's 6 months or more if they continue to qualify. About 1.8 million people, close to 2 million people are on hospice each year, but only 50% of them utilize the full benefit. And a lot of times it's because what we've seen is there's maybe not communication with your loved one, wanting to know and understanding what their end of life wishes are. And those conversations are super hard because, if you're like me, or if you're like yourself, sometimes grandparents or parents, they don't like to divulge information too much. And so there's a struggle between, what does mom want at the end, right? What does dad want at the end? And sometimes having those conversations are difficult, but if you can have those conversations early, then you know exactly how to honor them and honor their wishes. And that's what we see a lot of times, is that struggle to move that direction, if that is the direction that is needed, because of not knowing what mom or dad want. And so we've decided to do these Hospice 101 lives to kind of educate families, to help them understand what it is. And this week we've got a real story retold with Mr. Frank Delgato, baseball phenom. And so his story is awesome. It's pretty amazing. And we'll dive right into Mr. Frank. So Mr. Frank spent most of his life on the baseball field. He loved Little League, coaching in San Antonio, Texas. And of course, you guys know baseball is everything. And it's America's sport. But of course, sunflower seeds and not chewing tobacco, but sunflower seeds is the biggest thing when it comes to baseball. And that's what he loved. And baseball wasn't just his hobby, it was also his passion. He and his wife raised one son, Mr. Mateo, but his son now lives several states away. And so after retirement, he would spend most of his time coaching baseball in little leagues. And so that was what Frank loved, and that was his passion. And what happened was, he recently, when he was around 62, he suffered a stroke. And so one morning, he was waking up, and then he was unable to move his left side. And so these are stroke symptoms. We talked about this previously with a previous patient on our previous live, about the signs of stroke symptoms. And so be fast. Over the years, it was fast, but now it's BE fast. And so balance is one of the things that's added. The American Stroke Association added that in May. And then E is for eye, so vision. his vision started getting blurry. So all those were some symptoms that he started to see. Went to the hospital and they diagnosed him with a stroke. And so, he at that time in San Antonio, he was at San Antonio, then moved. Wanted to move closer to his other families over here in Dallas, Texas. And so, what happened was he was there at the hospital. Then he got transferred to an assisted living facility here in the Dallas area, and that's where we got to know him from a home health standpoint. And so, oh, let me go back one. There we go. So he was at the home health, at the assisted living facility, and then we took care of him on home health. And so he was doing great. So if you're not familiar with home health, what happens is in Frank's situation, he was at the hospital, then he got discharged home, and in this case, he was at an assisted living facility. It was actually a group home, it was a smaller place where he would get focused care, and so he had to pay into that for someone to be there for the group home, and then home health Part B through Medicare covered his home health services. So nursing, physical therapy, speech therapy. And he was making some really good progress, actually. He was on our services for about 6 months, did great. Discharge actually, and he was doing good. But the thing was is that after he was discharged, he started to decline, and we noticed that he reached back out to us, and then ended up in the hospital, which wasn't great. But the thing was, it became worse. He had more increase in falls, and then also not only that, his Mateo, his son was out of town, but he was saying that dad's not doing too good and is declining, and all these hospitalizations, and so the doctor was stating specifically maybe it might be time to consider hospice because he's kind of done everything he could. His body's done everything he could to maintain and to do the best that he could from a rehab potential, and the doctor was saying you should think about hospice services. And Mateo was like, hospice? What are you talking about? Like, dad's not going to die today. Like, why hospice? And so if you're hopping on for the first time, welcome. What we've been doing is we've been walking families through what hospice services is. We do home health, hospice, and personal care services over the last 20 plus years. And we've just seen a lot of confusion when it comes to what hospice is. And so in this situation, in this story, we're walking you through Mr. Danny and his story with his stroke path, and doing home health, doing well, and then also hitting a decline. And actually, now the doctor's stating he may be a candidate for hospice services. And so, what we're doing is walking you through what hospice is. And so, what is hospice? Danny's getting these news about hospice, and he's like, I don't want my dad to go through this. And so what happens? And so, what is hospice? Let's break down what hospice is specifically. So hospice is, think about it in three areas, three parts, right? Hospice focuses on managing pain and symptoms, emotional, spiritual support, supporting the family, and then also honoring patients' wishes. And where does hospice happen? Hospice can happen anywhere. It could happen at home. It can happen in Danny's case, a group home or assisted living facility, or even a skilled nursing facility or an inpatient unit in the hospital as well. So hospice is not a place, it is a benefit for families to receive, and it depends on where that patient or your loved one lives. And hospice, when is hospice appropriate? So this is where the doctors come in and state, based off of the clinical things that they see, especially with Danny in his case, if there's a life expectancy of 6 months or less to live. Now, nobody knows when someone will pass away. Only God does. And so, but what doctors do, and a lot of times hospital systems, and what they see is look at the clinical reports and see, okay, these are the things that we've seen, and the trajectory that will point towards end of life. And so that's where they usually make recommendations to say, okay, I think hospice may be something you may need to consider. And they do a recommendation. And then that's where we are now with Danny and Mateo, understanding, okay, what is hospice and what does that mean? And so when we talk about hospice, we like to talk about three things, right? The three components of hospice and what hospice is. It's broken down into a care team, supplies DME, and medications. And so what we're going to break down is these parts of hospice. Now, hospice is it's a very complex system. But if you can think about it in these three areas, it'll help you at least to digest what is going on and how hospice helps families and helps patients through their time. And so hospice care team, let's talk about the care team. So you've got chaplain, social worker, you've got a hospice nurse, an aide, and a medical director. So when you think about, let's start with the hospice nurse. So once someone starts hospice, they then qualify specifically based off of all the clinicals that are reviewed by the hospice team and the hospice nurse. So in Danny's case, he had a stroke, and so all of those compared to his heart, his brain, right? All those clinical things make markers make it to where he does maybe qualify for hospice. So the nurse will come out and review everything that's going on with Danny, review his current medications, review the medications that will be covered under hospice and not covered under hospice. We'll go into who pays for all of these services, but this is where the nurse comes out and reviews everything and creates a care plan based off of his wishes and also his medical power of attorney's wishes. So in this case, Mateo is his medical power of attorney because his wife is no longer alive. Danny's wife is no longer alive. And so now all the decisions now go towards Mateo, which can be very overwhelming if Mateo doesn't have an understanding prior to of what his wishes are. And I think that's where the struggle happens a lot with families is there's no clarity of like what happens when this is needed. And so in this situation, luckily, Danny had already talked to his dad and everything was already clear. And so he knew exactly what his will was, his end of life wishes. And so he didn't want to do anything except honor his dad's wishes. And in this case, the nurse had a very clear path on what to do. So the nurse goes in, does a complete head to toe assessment, reviews everything, orders the equipment, which we'll talk about later, reviews the medications, and creates a care plan for Danny to make sure he's comfortable because now Danny is at an assisted living facility. In this situation, he's in a group home, which is more intimate. So he's got caregivers that are there. The nurse is there to help make sure that clinically he is comfortable and he's continuing to enjoy his quality of life while he's there, not going back and forth to the hospital anymore, not going back and forth to doctors anymore. The hospice team becomes like a hospital at home for Danny to live and to enjoy his last days as long as he has. And so now the nurse goes out, does a care plan for the aide. So the aide can come out. And now when a lot of times we see this confusion when it comes to aides and hospice, Medicare covers these services, but it's not round the clock aide services. Medicare is specific about the aide who is a CNA, a certified nurse assistant. That certified nurse assistant has a license that's underneath the RN. So the aide can only do what the RN delegates. And so in this situation, the RN says, okay, let's go ahead and have the aide come out and do 3 baths this week, shaving, cleaning, hygiene, and then the aide goes out and does that accordingly. And so that's part of the hospice care team. The next person is the social worker. The social worker is now there to help kind of glue all the things together that Danny is or that Mateo is needing when it comes to funeral arrangements, living will, anything that needs to be notarized, DNR, all those things, so that Mateo doesn't feel alone in this whole process. And the social worker is also there to give resources or community resources as needed to help through this process. A chaplain is available. Now, all these are people that are available to families. A lot of families, even if they don't have any faith or religious background, sometimes a chaplain is just there to just talk because grief is real, and understanding the disease process and understanding that this time is coming, right? And even the things that Danny used to do, which is go and play baseball, you lose something that you love that gets you down, right? And having someone to talk to and process that is super helpful for families when it comes to a chaplain at times. And then the medical director. So under hospice, the hospice nationwide, every hospice has a medical director and hospice physicians. Their job is to oversee what's going on clinically with Danny and his disease while now he's on hospice. And so those doctors are usually the ones who coordinate everything instead of the PCP that Danny usually has been with over the last several years. And so, because hospice doctors are specialized in end of life pain management, comfort. Usually those PCPs will coordinate or defer to anything that has to do with hospice to the hospice doctor, because the hospice doctor can quickly coordinate meds, and those meds can get there pretty quickly, especially at the end, which is so important for comfort and quality when it comes to patients and comes to families. So that's the care team. Summary, brief, but that's the care team. Next is medications. So we talked about this. Underneath hospice covers specific medications that are tied to the terminal diagnosis for Danny, and then there's other ones that are not tied to the terminal diagnosis. So Medicare will cover those terminal diagnoses under hospice medications, and the ones that aren't are then covered under Medicare, but not under specifically hospice. So the nurse will go out, like we talked about, the quarterback goes out, reviews the medications, and deems which ones are covered and non-covered, and then Medicare will then pay for those services under hospice. And a lot of times what the best hospices do that we've seen is that they'll make sure to educate the family on these things so they have a full understanding of it. And then some hospice, what they'll do is they'll go ahead and order all the meds, so then the headache of coordinating that, or Mateo or anyone else, is now absorbed by the hospice, and the hospice will order those meds, drop shipping at the group home, coordinate that, make sure that the group home knows exactly everything that's happening with the MAR, which is the medication record. And so all those things are done effectively and efficiently so that there's good care coordination. And then let's say something's happening. Let's say Danny's declining and he's not doing too good. Then what happens is that group home will then reach out to the hospice nurse and coordinate quickly on any changes in medications that need to be addressed and done, and collaborate that plan with Mateo, so there's awareness of what's going on. Because a lot of times what we see is, unfortunately, there's just so many things when it comes to hospice and bad stigmas, because it's not enough communication with the hospice team and the patient and the family on what each medication does. And so the best hospices, what they do is that they'll make sure, okay, this is what morphine is used for in this specific situation when it comes to what he needs. This is what lorazepam is used for. This is what all these controlled substances are used for when the time comes, and not just pushing those medications. And a lot of times we hear a lot of stigma about, oh, morphine is just used to kill people, or all these meds, hydrocodone is just used to kill people. And so these medications are used in conjunction when the disease is taking its toll, and quality and comfort is what is needed for the patient, not just to use them. And so that's very, very important. And that comes with trust as well, when you develop a bond and a relationship with that hospice nurse to guide you and educate you on what's going on with your loved one. And so that's where medications are also coordinated and effectively done by the hospice, so that there's clear coordination. So it's super important. Next is DME, durable medical equipment. So these are the equipments that are used for patients under hospice. And so what hospices do is they contract with a durable medical equipment company. Now, they don't own the equipment. They contract with these companies, and then the companies deliver those DME equipments to the home. So in this situation, Danny already had a bed in the group home, so there was no need for the hospice nurse to order that, but she did order a bedside table, right? Oxygen, all those things. And then she also ordered gloves, chucks, incontinence material. All those things are ordered by the hospice, and then usually sometimes drop shipped or hand delivered, depending on the hospice, to the group home on a weekly or bi-weekly basis, right? So that way it's a beautiful thing, because now Mateo doesn't have to go to Amazon every week and click on Amazon and order specific incontinence depends and chucks for his dad, which is a beautiful thing, right? And this is all part of the benefit of hospice services. And now each hospice has a list. Now, if you want Cadillac, the really, really nice things, these are all covered by the government, right? And so a lot of times those things, if you want something that's really nicer, high end, and families will go on their own and buy those things. But it's always good to utilize what Medicare will give you through these services, instead of spending your own dollars to do that. So it's a nice, big benefit and a help for families. So where do I start? So now that Mateo kind of understands everything that's going on with this, he now is like, where do I go? Where do I start? And so we talked about um, the steps. So recognizing that it may be time, and that happened at the hospital when the doctor was like, "I think you may need hospice services," and then the order was then written by the doctor. Now Mateo has to choose which hospice works. And that's sometimes really hard, right? Because there's so many hospices out there. But the things that we talked about today helps you understand what the best hospices do and how they specifically tailor and create a good care plan for Mateo and for his dad, right? The best hospices do that, right? And the best hospices are making sure that they are everyone's included in the plan of care. Now, no hospice is perfect. You're always going to find a hospice. There's always going to be an issue, just like anything, right? But knowing that you can have a good relationship with the nurse, with the team, or with the administration in the office to say, "Hey, this is what's happening. This was an error. I want to make sure. Can you help? Can someone help me understand what's going on?" As long as you have that with your hospice, and that will allow for good care coordination. That will allow for a good outcome, right? And then the admission begins, right? When everything is reviewed, the clinicals are reviewed, qualifications are then met, and then the nurse goes out that we talked about, the quarterback goes out and does the admission. And so these are the qualifications that we talked about. Clinically, not everyone can qualify for hospice services. It's only based on those clinical metrics that are met. So you've got the heart, you've got the lungs, you've got the brain, you got the ribbon for cancer, you got this old man with a walker for debility, and then you've got blood, right? Blood cancers and hematology and things like that. So those are all the different diagnoses that are qualified. And so each of these have specific LCDs or local coverage determinants that make it to where someone will qualify for hospice services. Now, if those are met, then someone can be admitted to hospice services. And so that's just one piece. And then the next piece of also is insurance. Like who pays for all of these things that we talked about, right? So Medicare Part A covers for hospice if someone has of Medicare age, 65 and older. So if you don't have Medicare Part A, then you can't get these services. If you are less than 65 and you have like Blue Cross Blue Shield, Aetna, Humana, all the other commercial plans, then what we usually advise families to do is reach out to the insurance carrier and see if there's a hospice benefit. And if there is, then reach out to them. And usually what they do is they'll give a list in your area of these are all the hospices that are contracted with this specific insurance to receive hospice services. And so those are the two things. And so now if you have Medicare Part A, all the things that we talked about are 100%. There's no copays, there's no out of pocket, right? There's none of that, right? It's all covered. Now, if you want the higher end things or the nicer things or more care, or if you want someone to be at the bedside, right, consistently, right, that's where you pay out of pocket for certain things like that. Or if you want something, a little bit nicer or more things, and that's where you would pay out of pocket. And so these are the things that are covered under insurance under Medicare Part A. So now, Danny was admitted to hospice services, and he's doing okay. He's at home. Let me switch this and see if you can see that. There we go. And so he's now on hospice. He's got a nurse there. He's got equipment. He's got a chaplain, and Mateo is doing pretty good, right? He's not carrying the burden of all the things that he used to carry now, and he's got that support, and he's got the clinical support where if he has questions, he can call the nurse. If he has questions, he can call the hospice office, and reach out. And the biggest thing is, now there's a somewhat of a relief. Now the journey doesn't get easier. That hospice is there. There's just more support, right? There's more help. There's more guidance clinically, right? And so these are the things that when you think about healthcare at home, these are the pillars that are broken down when you're talking about home health. Then you have personal care, then you have palliative care, then you have hospice care, right? So Danny went from home health and then personal care. He had that in a way because he was at a group home. So he's paying someone monthly to be at a group home, right? There's also personal care where you pay someone, depending on the rates and depending on the area, anywhere between $35 to $40 or so for a company, or you can pay individually to a person to be there at the bedside to help with meals and cooking and things like that, right? And then palliative care that's if you're continuing to do more aggressive treatment. Now, palliative care isn't a benefit underneath Medicare. So all the things that we talked about under Medicare Part A is all hospice services. Hopefully, there'll come a time where Medicare will be covering fully certain items underneath palliative care, but at the moment, anything that has to do with Medicare Part A and B is fully covered under home health and fully covered under hospice services. And so then we talked about hospice services and him understanding the need of clinically what he can get under hospice. Mateo, his son, was in agreement, and all those things came into play. And so, yeah, those are the things that a lot of families have a lot of questions on, and it can get really confusing, to be honest. Like I wouldn't, for me, I've been doing this now for 10 years. My background is physical therapy. So I worked at a hospital and, I only knew what was in the hospital, right? When you're in the hospital, you're doing physical therapy, you're getting better, and then you go home. But that world of home health, the world of hospice is it's foreign to people. And it's only when you really need it that you're like, oh my gosh, like, what do I do? Like, who do I call? Like, it's not like you can just call your friend and say, hey, where do I go for hospice, right? Or it's not like you can call your friend and say, hey, what do I do for home health for my mom, right? And that's just why one of the main reasons why we're trying to make this education so easy to understand, so that way anyone can just watch this and figure out, okay, at least I have a good understanding of what it is, and then I can start making decisions and doing some more research. So I hope this helped you guys. I hope this was informative. We're going to keep doing this. Sometimes it'll be weekly. With work, we're in healthcare, so we're always buzzing. So sometimes we'll do our best to do it weekly, but if not, we will always bring this to you guys a couple times a month with education, and help you understand what hospice is, also what home health is, as well. So feel free, if you're in the Dallas-Fort Worth Metroplex, reach out to us, call us. If you have any questions, we're more than welcome. Our team is more than welcome to at least guide you. If we can't serve you, then we can point you in the right direction so that you know what the steps that you need to take for your loved one when it comes to home health or hospice, veteran care services, or personal care services. So God bless. We'll see you guys next time.